Shield medical scheme, we don't just talk health, we do health.
HIV/AIDS is a danger to all our people, young and old, rich and poor, men and women. HIV/AIDS is worse than a war. As we speak now, there are thousands of people dying from it this moment. But this war can be won. This is one war where you can make a difference. Protect your life and the ones you love by ensuring that HIV/AIDS is not a part of it. Each one of you, protect yourself and those you love. I love you, and I thank you for caring about your future and about the future of all of us.
In July 2000, in his closing address at the 13th International AIDS Conference in Durban, former President Nelson Mandela described HIV/AIDS as a tragedy of unprecedented proportions that was unfolding in Africa with a devastating impact on families, communities, societies, and economies. Madiba said there was a need for us to be focused, to be strategic, and to mobilize all of our resources in partnership with the international community and to sustain the effort until the war on HIV/AIDS is won. It is now 16 years later, and the world has again descended upon Durban to tackle the very same issue, HIV/AIDS. More than 18,000 delegates gathered at the 21st International AIDS Conference, which kicked off on Mandela Day, July 18th. So today we reflect on HIV/AIDS and examine how far we are in the war against the pandemic. Our guests today include the Director of the Center for the AIDS Program of Research in South Africa, or CAPRISA, and a Research Executive for HIV/AIDS, STI and TB at the Human Sciences Research Council, or HSRC, National General Secretary of the Treatment Action Campaign, or TAC, and someone from the Advocacy for the Prevention of HIV and AIDS, or APHA. So sit back, relax, and learn from this bumper show we have for you today. I'm Dr. Saloma Daum, and this is Health Talk.
Fewer people are dying from AIDS-related causes. At this conference, we will hear the debate, the advances, how far we have advanced in terms of research. We will hear about better drugs, about strategies that have reduced the rates of infection and improved access to treatment. But we will also hear that the struggle is far from over. We will hear that there is still much more to be done. In the face of this, we dare not be complacent. Michel Sidibe says he is fired up. In fact, we should just all be on fire as we confront this epidemic. We know that the rates of infection are not declining as rapidly as we would like them to decline. We know that adolescent girls, as well as young women, are particularly at risk. Their vulnerability derives from social attitudes and economic circumstances. In South Africa, each week, we have an estimated 2,000 new infections in adolescent girls and young women that are aged between 15 and 24 years. We know that our inability to effectively reach key populations who are at increased risk of HIV infection is perpetuating their marginalization. Our failure to reach them is hampering our efforts to decisively reduce the spread of this epidemic.
Okay, now to get a lot deeper into the issues of HIV/AIDS and the 21st International AIDS Conference in Durban, it's a great pleasure for me to welcome our two guests. First up is Professor Jeffrey Setswe. Professor Setswe is the Research Executive for HIV and AIDS, STI and TB at the Human Sciences Research Council, or HSRC. And with him is Professor Salim Abdul Karim, Director of the Center for the AIDS Program of Research in South Africa, or CAPRISA. Gentlemen, thank you very much for your time and welcome to Health Talk.
Thank you.
Thank you.
All right. Let's perhaps start with you, Prof. Abdul Karim. Now, perhaps just briefly take us through the theme of the conference and perhaps the significance of the conference, especially that it is hosted here in Durban. I mean, the first time it was hosted obviously was 16 years ago. And of course, we know what the problems are with regards to statistics in that region. Do you want to perhaps take us through that?
Well, when I think back 16 years ago, when we organized the conference in this very same ICC here in Durban, we were dealing with a completely different HIV epidemic. We were dealing with a situation where patients were dying, we had no access to treatment, we had huge disparities in terms of the ability to really deal with the essence of the problem, which was the very high deaths and death rates and infection rates. The situation today, 16 years later, is very different. We have a different epidemic. We have 17 million of the 37 million already on treatment. But the challenges of the inequity of access, the inequity in our ability to slow the HIV epidemic still remain. And so this conference set itself up to address those very issues that are the kernel of the problem that we see in HIV. And that is the ability to deal with the human rights issues, the access issues, and the equity issues in overcoming the HIV epidemic.
Okay. So generally, I mean, if we look back over the last 16 years, there seems to have been some progress that we've made. But clearly, as you said, there are still challenges. Now, Professor Setswe, perhaps may I just ask you to just comment on the current trends in the HIV statistics?
We are now talking about an epidemic that has got about 38 million people infected. But if you look at where we were in the year 2000 when we hosted the AIDS conference, I think there has been a decline in new cases of HIV/AIDS, which is encouraging, but the decline has not improved since 2005. So between 2000 and 2005, we were seeing a good decline. But there's also been a good decline in number of people who die from AIDS-related diseases, which is encouraging. And a substantial increase, as Prof. Slim indicated, in those who are receiving ARV treatment. For example, in just 1 year, in the last 12 months, 2 million people were added to those who are receiving antiretroviral drugs, with South Africa having the largest number of people receiving antiretroviral drugs. So we're doing extremely well, but there are gaps, in the epidemic. There are young women, for example, who are at a higher risk of getting infected as compared to men their own age, those that are in the age group 15 to 24. We also have got key populations that are still seeing a rise in the HIV epidemic among them, whether it's sex workers, men who have sex with other men, people who inject drugs, and so on. We also have got migrants and prisoners, so we need to look at those key populations. They are at a higher risk of HIV/AIDS. But the conference has been able to show that we are now working a lot better together When we were here in the year 2000, politically, the human rights issues were a problem. The president of the country at the time had his own views about HIV/AIDS, but I think we seem to be more united, and we seem to be knowing where the gaps are, and we're able to intervene.
In his opening, the Deputy President, Cyril Ramaphosa, hinted that perhaps we might be a little bit complacent, thinking that we've made too much progress. Is there any merit in that? Have we been a little complacent, perhaps?
When we think about the progress that has been made and the resources that have been mobilized in order to expand treatment, and particularly the gains that we've made, for example, in prevention of mother-to-child transmission, all of these have sent a signal out to the broader community that we are winning the battle against HIV, that we have made good progress, that HIV is no longer a death sentence, that it's a disease we can now cope with in a lifelong way. So that sometimes gets misinterpreted like this problem is over. But think about it for a moment. In 2015, there were 2.1 million new HIV infections, the same number in 2014. Now, we can't say that we have a problem that is over when you still have 2.1 million new infections. We cannot have a situation where we say the problem is over when we still have close on to 22 million people that still need to go on to treatment. So as we think about the way in which the state of the epidemic is being conveyed, it is sometimes misconstrued that the problem is over and we don't need to worry about HIV anymore. That's simply not true.
Another question related to that, Prof. Abdul Sarim. Can we really talk about ending HIV/AIDS by 2030?
When UNAIDS was trying to establish what we should set as our global goal, they called together a large group of scientists, activists, and people who've been involved in the battles against HIV over many years. And we all sat down and said, is it feasible to end HIV by 2030? And the answer to that is that yes, it is feasible. But it's only feasible if we put our shoulders to the wheel and if we get the kinds of resources that are necessary to really roll out antiretroviral treatment, to roll out prevention, and to ensure that we can drop the number of new infections right down to close to zero. That is not going to be easy. And given the current state of the HIV epidemic, and given the challenges we're facing now in terms of the funding that's available, that is looking like nothing but a distant dream. I am hopeful that if we set our target as ending AIDS, then we understand that that's an aspirational goal. We understand that we may not actually get there, but we want to get as close to that as possible. And we want to do as much as we can to try and reach that goal.
All right.
Better that than setting some kind of goal that ensures that we will meet it, but is too low a bar. Each day, every person that gets HIV infected is a tragedy. Mm-hmm. We have to look to some kind of time point where we will end that tragedy. If not 2030, then perhaps several years beyond that.
All right. It's on this note that perhaps that we go for a short commercial break. After the break, we continue our discussion and we understand why young girls are disproportionately affected by this pandemic. Please stay with us.
MedShield Medical Scheme, we don't just talk health, We do health. SMS MedShield to 33023 or talk to your broker to get your kind of care.
So good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est bon.
MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well.
News Today provide news updates giving a wealth of knowledge. Breaking stories and crossing live for you. We follow business developments intensely. Experts and analysts tackle all challenging issues for you. We cover stories locally and abroad to keep you informed. We cover all sporting codes just for you. We are sure to give you weather to be ready for the day. Stay tuned to News Today at 3 p.m. from Monday to Friday on SABC News.
AIDS does not discriminate on its own. It has no biological preference for black bodies, for women's bodies, for gay bodies, for youth or the poor. It doesn't single out the vulnerable, the oppressed, or the abused. We single out the vulnerable, the oppressed, and the abused. We ignore them, we let them suffer, and then we let them die. My foundation, CTOP, and a number of our colleagues are calling on today's youth, to the young people, to be the generation that ends this epidemic, to be Gen End It. I just want to be clear about what the it in that sentence is. It is not just AIDS. It is the culture that condones rape and shames victims into silence. It is the cycle of poverty and violence that traps girls into teen marriages and forces them to sell their bodies to provide for their families. It is the racism that allows the white and the wealthy to exploit the black and the poor and then blame them for their own suffering.
Welcome back. We're still with our two guests, Professor Jeffrey Sitso, Research Executive, HIV/AIDS, STI and TB at the Human Sciences Research Council, or HSRC, and Professor Salim Abdul Karim, Director of the Center for the AIDS Program of Research in South Africa, CAPRISA. Now, back to you, Professor Sitso. You just before the break, you wanted to say something on the issue around whether or not we can end AIDS by 2030. Very quickly.
Yes, I wanted to say that there are some wins in the age group in young people where mother-to-child transmission, we have done very well. South Africa is one of the countries, including Botswana, that have done well in reducing mother-to-child transmission. In fact, several countries will have eliminated mother-to-child transmission of HIV/AIDS. And I think to get to the goal of ending AIDS by 2030, we need to target different age groups. Those that are on treatment, if we can be able to keep them on treatment so that they get virally suppressed, and we continue to ensure that the prevention programs are functioning as well as they should be. I agree with Prof. Slim that it's going to be difficult, but we needed to get an ambitious target. It is not good to have a target that does not give you something substantial.
Yeah. Let's talk for a moment, Professor, about the rate of new infections and the fact that, you know, we have sub-Saharan Africa disproportionately affected by this, and in fact, young girls being disproportionately affected. What do the statistics tell us?
We're seeing an increase in HIV/AIDS among young people. The rate of new infections had stabilized, but we're worried that in 2014 and 2015 we had almost the same number of new infections all over the world. And sub-Saharan Africa, in the top 10 countries with new infections, would have 9 of the top 10 countries. And it's because the epidemic has hit us very hard in this part of the world. And we now know the groups that are most affected. We know it is young women, 15 to 24, who are mainly infected by older men. We know that it's key populations, and so the interventions now have to be directed at those in particular. But also, we should guard against the complacency in the groups that are doing well.
Yeah. Just finally, for a moment, Professor, you know, we're told that whereas sub-Saharan Africa, and in particular Southern Africa, seems to be doing well and has achieved, you know, the successes that we spoke about earlier, but other regions in the continent, specifically Central Africa and West Africa, seems to be lagging behind. Your comment on that?
I think the epidemic is coming up. You are seeing now Nigeria is, in terms of the prevalence, has shown an increase, and we're seeing an increase in some countries in Central Africa. The epidemic did not affect us equally. It was disproportionate in the way it affected us. So there was a lag in the time in which they got the infection hit them hard. I think we were hit hard a little earlier in Southern Africa, and it went to East Africa, and now some areas of West Africa. So the epidemic, you know, has not been proportionate in the way it affected different parts of the world. Even the Middle East and North Africa, you are starting to hear that the prevalences are going high up, and it is among key populations. You also hear, for example, in Eastern Europe, that the prevalence goes up among people who inject drugs. And so different parts of the world would have different types of epidemics. While in Southern Africa, we had a strong heterosexual epidemic. Now we have an epidemic that is going very fast through key populations in other parts of the world.
All right. Prof. Abdul Salam Karim, now the issue around young girls having higher exposure levels, I believe that you have some answers for us. Why should young girls be disproportionately affected by this pandemic?
So we've known for a long time that the prevalence of HIV, now the overall proportion of young women who have HIV, is much higher in women than it is in men at the younger age groups. What we were not able to understand was what was underlying the overall way in which the virus was being transmitted within our communities. So we did a study here in KwaZulu-Natal where we tested close on to 10,000 people. We were able to sequence the viruses from just over 1,500 of them. So what does that mean in terms of viral sequences? We look at the genetic code of the individual viruses. And through that genetic code, we know exactly who has the same virus or a very similar virus. So in other words, we know that these 2, 3, 4 people all acquired the same virus. And we can then work out how this virus was transmitted among them. So when we look at that, what we see is that this what we call a cycle of HIV transmission, which starts with very high HIV incidence rates in the young girls, the adolescent girls, young women below 24. And they are getting largely infected from men close onto their 30s. But what was fascinating for us was that about 2 out of every 5 of those men also had a virus that was similar to a woman in her 30s. So that told us that this cycle is as follows. Young women have high rates of infection. As they grow older, when they reach their 30s, they are now having sex with men, and men are having sex with them in order to find their wives and their husbands. At that age, women who have very high prevalence of HIV are leading to high rates of infection in men. Those men are now recently infected, they have high levels of virus, most of them don't even know they have HIV, also are sleeping with young girls. They are then infecting these young girls, and these young girls will grow up again in their 30s, have high levels of HIV, and continue the cycle. So this is the engine that drives the overall HIV epidemic.
But the issue of
we had
age...
sort of had circumstantial evidence to suggest this. So what we have now done is we've been able to prove this using these genetic codes.
But the issue of, age disparate sex is not unique to Southern Africa, isn't it?
So age disparate sex, when we look at the overall prevalence rates of HIV in young men and young women, almost all of the countries in Southern and Eastern Africa have this picture. Now one has to remember that Southern Africa and Eastern Africa combined account for about 70% of the global burden of HIV. And it is in those very countries that we see this disparity between young boys and young girls. So if young girls have high rates of HIV infection, and if they're not getting it from young boys because those boys don't have it, they are obviously getting it from the older men. And this is a challenge we grapple with in most of our societies in this part of the world. Now, some people tell me, well, actually age disparate sex is common everywhere. It's common in the US and everywhere else. Well, there's a different level of disparity that you see. When you start having a disparity where 18-year-old girls are sleeping with 32-year-old men, that is a very different level of age disparity than 18-year-olds sleeping with 22-year-olds. So it's this huge age difference that ensures you're able to drive the HIV epidemic. Let me explain that in another way. If young girls only slept with young men, then everybody who's going to get HIV will get it quickly, and then the epidemic will burn itself out. But when you have this disparity, you create almost like a never-ending supply of young women who are at risk of HIV. So you're able to maintain high rates for a long period.
It's a complex program.
That disparity is important.
Yeah, it appears to be a complex problem that obviously needs all of us to get together in fighting this scourge. We're going to go for a quick commercial break. After the break, we'll look at prevention strategies that can be effective for HIV. Please stay with us.
Shield, embracing our members in good health since 1968. MedShield Medical Scheme, we don't just talk health, we do health.
For Spile, giving up was no option even in times of need.
If it wasn't for the opportunity that was given to me by the taxi owner, late Mr. Sibego, maybe I wouldn't be where I am.
The taxi industry is also occupied by people with a vision.
There are quite a few taxi drivers with at least matric, and they had a next door neighbor who owned taxis, and they asked him for a job.
He now owns a law firm, and he believes that challenges are meant to be conquered.
Once you step on top of them, you are able to be on another level and they remain under your feet.
He says hard work granted him his dream of becoming a lawyer of note.
I don't really believe in miracles. People work.
Join Puleng Mulibati every Friday at 17:30.
Welcome back. We're discussing HIV/AIDS, and we have two special guests, Prof. Salim Abdul Karim, Director of CAPRISA, and we're now joined by Yvette Raphael from Advocacy for the Prevention of HIV and AIDS. Welcome to Health Talk, Yvette.
Thank you.
Perhaps let's start with you, Yvette, on the issue of prevention. Firstly, may I ask you to just tell us a little bit about what APA, or Advocacy for the Prevention of HIV/AIDS, is, and what do you guys do?
APHA is an organization or a program that's designed into leading the advocacy for prevention of HIV and AIDS, as we currently know that we have not made much progress in South Africa around prevention of HIV and AIDS for young women and girls. However, we do know that there's a lot of research going on. There's the Depivirine ring, and there's pre-exposure prophylaxis, there's PEP, and treatment as prevention as well. And we felt as advocates, as activists, that it's time for us to take the lead and drive prevention so that we can see some a downturn in the new infection rates in South Africa. What's currently happening is horrifying and it's scary, and we're actually at code red.
All right. Let's look at some of the enablers and barriers for success in prevention programs. And perhaps let's talk specifically around the issue of awareness. Do you think that there's enough awareness out there?
I think we passed the awareness phase. What we currently need as a country and as South Africa is a lot more of empowering young women, empowering people to make those decisions themselves around sex and their sexuality and how they interpret this HIV and how does HIV and AIDS fit into their lives. And I think that's where we're lacking, where we want as advocates to give people living with HIV and all our communities the right to make those decisions for themselves.
What about the issue of stigma and discrimination? Do you think that's still a problem in South Africa, in southern or in this region?
Yes, definitely. There's still a lot of stigma going around. We had the launch of the stigma index, or recently at the AIDS conference as well, and we see that a lot of people still feel stigmatized because they do not understand HIV and living with HIV. So we need to go back a little bit to the drawing board and going back to understanding what it means to live with HIV and AIDS. We also have a problem. A lot of men are not testing, are testing on proxy, believing that once their partners are testing HIV positive or negative, it means that's their test results. And we know with treatment that is not possible. So we're encouraging more men to get tested, and that's what some of the programs on the ground are doing, and we'd like that to continue.
Okay. Prof. Salim, what is it that we're doing right and what it is that we're not doing right in our prevention campaigns?
When we look at the overall HIV epidemic, we can identify some clear areas in which we have had successes. The clearest of those is when we look at mother-to-child transmission. We have had very dramatic decreases in the proportion of children who are becoming infected. We still continue to have some infections in a region of around 1 to 1.5%, and those are now in the process of being addressed through breastfeeding transmission. So we will see South Africa being very close to the elimination of mother-to-child transmission within the next 2 to 3 years. The same, however, cannot be said about adolescents, particularly adolescent girls and young women. There, we see ongoing high rates of HIV infection. If we are to really break the back of HIV in this country, we have got to slow that HIV incidence, and we've got to stop new infections in that group. So why is it we're seeing these high rates? We've already shown through these studies on genetic codes of viruses that the most of those infections are occurring from older men. But we cannot solve those kinds of issues simply by putting in place biomedical interventions. We have to change community norms about what it is that encourages young women to sleep with older men, encourages older men to sleep with young women. This is not about blaming anybody. This is about understanding the problem and finding solutions that get to the root of it. Because if we simply put a Band-Aid on these problems, we will not slow the HIV epidemic and end it as we would like to by 2030.
Whilst I have you, Prof. Salim, earlier we spoke about the issue about vulnerability of especially young women, and there's the notion around, the vaginal flora, a specific type of bacteria that some women carry around that may put them at risk of further transmission. Perhaps do you want to comment on that?
We've always understood that there are these very high rates of infection in young women. What we've not been able to understand is the relative contribution of behavior, the social circumstance, and biology. We have sort of tried to grapple with all of these in a way that has muddled them up. Now, by using very sophisticated technology, we were able to sequence the bacteria that are present in the vagina of women, particularly young women. We found over 3 million different sequences. There are more than 25,000 sequences in any one swab from a woman's vagina, giving you some idea of the diversity of the different kinds of bacteria. Looking in detail in that situation, we discovered that one particular bacterium by the name of Prevotella bivia. When a woman has an infection with Prevotella bivia, she would have a 13 times higher chance of getting HIV.
Can we test for this bacteria?
It's not a sexually transmitted infection. So it's not like these are particularly promiscuous women who have Prevotella bivia.
Yeah.
But in the circumstance where this bacterium is allowed to grow, we have a situation that women become particularly vulnerable to HIV.
I was just asking, can one test for this bacterium?
Yes, so it's actually relatively easy to test for an indicator as to whether the bacterium is there. To actually look for the bacterium itself is actually not that easy. But because this bacterium only grows when the pH of the vagina is no longer acidic. In other words, the vagina is a complex balance of lactobacilli and a range of other different kinds of bacteria. Lactobacilli are the good bacteria. They show when you have lots of lactobacilli that the vagina is healthy. Lactobacilli produce lactic acid. They bring the pH of the vagina into the acidic range, which makes it hostile to HIV and everything and all other organisms. However, when lactobacilli are no longer dominant, when lactobacilli are now receding, these other bacteria take over. And so we can simply measure pH. It's this little dipstick. Every clinic has it. It's a very easy thing. Women can do it themselves if they wish. Based on that, you read the color, you know the pH. If a woman has a pH above 4.5, she needs treatment. The treatment itself is pretty straightforward. It's a simple drug, readily available, called metronidazole, and that would then treat the Prevotella. It would treat the Gardnerella. It would treat all the bad bacteria and enable the good bacteria to come together.
All right. Well, Let me take this opportunity to thank you very much, Yvette Raphael, Advocacy for the Prevention of HIV/AIDS, APHA. Perhaps, in future programs we'll have more time to get to understand what you do a little better. Now, after the break, we focus now on treatment and look at the way forward. Please stay with us.
MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well. MedShield, embracing our members in good health since 1968.
Did you go to heaven?
Kelvin is the one who created all this.
What are you fighting over? Us?
If there is 10 million in my account, it will be in the front page the next day.
Do you have 10 million?
Oh, Jesus, hold my hand. Hallelujah.
It's happening right here on Question Time today.
Monday to Thursday at 5:30 p.m. on the SABC News Channel.
News Today provide news updates giving a wealth of knowledge. Breaking stories and crossing life for you. We follow business developments intensely. Experts and analysts tackle all challenging issues for you. We cover stories locally and abroad to keep you informed. We cover all sporting codes just for you. We are sure to give you weather to be ready for the day. Stay tuned to News Today at 3 p.m. from Monday to Friday on SABC News.
Thousands of protesters took to the streets of the South African city of Durban on Monday, demanding access to treatment for the 20 million people across the world suffering from AIDS and tuberculosis. The march by members of the Treatment Action Campaign and civil society was held as Durban hosts the 2016 International AIDS Conference.
This is a global march for access to antiretroviral treatment for the 20 million people in different parts of the world who still do not have treatment and who are still dying of AIDS and dying of tuberculosis.
South African-born actress Charlize Theron and celebrity guests at the 2016 Global AIDS Conference.
HIV and AIDS is the #1 killer of adolescents in Africa, sub-Saharan Africa. It is the #2 killer of adolescents globally. Why are we not caring about that? This is not something that just affects Africans. This is a nationwide, worldwide, global-wide issue. Our young people are dying at a rate that should frighten us. And yet somehow we just don't talk about them at all. They are the forgotten ones.
The South Africa that hosts the Global AIDS Conference this week has come a long way from the AIDS Peria that did so 16 years ago, when then President Thabo Mbeki stunningly dismissed the link between HIV and the disease. At the epicenter of the worldwide AIDS pandemic, South Africa now boasts the largest treatment program in the world, with 3.4 million people receiving antiretroviral drugs that allow those living with HIV to lead normal lives.
The fight against HIV, AIDS, and TB is not over. Too many people living with HIV still do not know their status. Too many do not have access to treatment. The rate of infection remains stubbornly high, particularly amongst the most vulnerable populations in the world. We know, for example, that adolescent girls and young women between the ages of 15 and 24 accounted for around 20% of new infections globally last year.
Today, 7 million South Africans, 19% of the adult population, live with HIV.
All right, now to talk a little more about the issue of HIV treatment, we still have Professor Salim Abdul Karim, Director of CAPRISA, who is now joined by Anele Yawa, the National General Secretary of the Treatment Action Campaign. Anele Yawa, welcome to Health Talk.
Chap, how are you?
Good, how are you? All right, perhaps let's start with Prof. Salim. Now, earlier we were talking obviously about prevention, and now there's the issue of pre-exposure prophylaxis. Please just take us through what this is and what significance it has in both the prevention, obviously in the prevention of HIV.
So one of the newer technologies that we have now been able to use effectively and through clinical trials have shown to be effective is the use of antiretroviral drugs by people who do not have HIV in order to protect themselves from getting HIV. Now that's not a totally new concept, because we've used this idea in preventing the spread of HIV from mother to child. What we did not know was whether this would also work if we used it to prevent sexual transmission. So in 2010, at the AIDS conference in Vienna, we provided the first evidence that that was possible. Since then, there have been several studies that have confirmed this. So what does this actually mean? It means you have to take a drug called Truvada. Truvada is a combination of tenofovir and emtricitabine. Using this combination of drugs and taking a tablet every day, you would reduce the risk of getting HIV should you sleep with an HIV positive individual. So it's a prophylactic, it's a prevention mechanism using the same drugs that would otherwise be used in treatment.
And who must use this drug?
So the World Health Organization has looked at all of the evidence, and in their recommendations, in their guidelines to the world, they recommend that this drug or this approach to HIV prevention would be particularly suitable to individuals at high risk of HIV. They define high risk of HIV as those groups in whom HIV incidence is above 3 per 100 person years. In other words, over 3% of people are becoming infected. Now that rate applies quite widely in South Africa, particularly in KwaZulu-Natal, where most of the different groups would have such high rates. Okay. Our government, in reviewing the evidence and the recommendations of the World Health Organization, has decided to prioritize two groups. The first is sex workers, where we already know they have a high rate of HIV. And the second is in men who have sex with men, where we also know and we have seen high rates of HIV. So those two groups are prioritized. What we anticipate is that the government will be making a decision soon to expand that to a range of other groups, including one of the highest risk populations of young women. The challenge with doing that is that the government has to ensure it has adequate supplies of the drug, that it has healthcare workers who know how to do this, and it has to be said that it's not a difficult thing to do. It's like taking treatment for diabetes or hypertension. It's just simply a question of ensuring that when we put patients onto a prevention modality like PrEP, that they continue to use all of the other prevention approaches like condoms and so on. So PrEP is seen in addition to and not instead of.
Okay, let me bring in Mr. Yawa in here. Another, you know, we just spoke a little earlier about the successes we've had, you know, looking back over the last 16 years, you know, the rollout of antiretrovirals. There's talk of the new 90-90-90 campaign to, in fact, you know, treat and test test and treat a whole lot of people. In other words, expand the rollout of ARVs even more. What are your views generally around issue of access to treatment for HIV?
Okay. Firstly, in 2000, we had challenges of access to treatment. We had challenges of denialism, of quacks, discrimination, and stigmatization. And through the advocacy work of a civil society, we managed to force our government to make sure that the access to antiretrovirals is available within the public healthcare sector. And we are saying we did a good job, because now we are having about 3.4 million people who are estimated to be on ARVs. But also we are saying it is not enough, because one of the things that many people are not comfortable to hear or talk about is the fact that let us not rush numbers. Let us make sure that we provide quality in terms of access to treatment.
So
as I'm talking to you, if you go to the level of the clinic, you will find out that there are many people who are lost on follow-ups. And our government and those in authority, they are not coming public and say, out of the 3.4 million people who were initiated or who are on treatment, how many people who are lost on follow-ups. And also the other challenge is the issue of defaulter rate and the non-adherence. Many people who are living with HIV and AIDS, especially the black poor, are always or are often being denied access to treatment by the public healthcare system, which is broken. Like, let's take a typical example for a person who stays in a deep rural area in Tlinci, here in KZN. People of Tlinci village, they walk 10 kilometers from home to the health facility and 10 kilometers back. Or if, so it means if they don't get treatment, their rights are being violated, and the system is forcing them not to adhere because of issues of shortages of drugs and drug stockouts. So the World Health Organization and the UNAIDS, the first World Health Organization came up with the new guidelines of universal test and treat, PrEP. And we are saying yes, it's good, because it means anyone who is tested HIV positive, irrespective of its CD4 count, they must be initiated on ARVs. Same applies with the PrEP. But the question that we are asking ourselves, globally there are about 37 million people who are living with HIV and AIDS. Only 17 million people who are having access to treatment. What about the 20 million? So also, when you talk about issues of PrEP, it is about issues of accessibility, and because if you're talking about male having sex with male, let's go to prisons. How are the prisoners or inmates are going to be able to access this service of PrEP? Because we all know that if you don't have a number in prison, those who've got a number, they will force you to you will be forced to sleep with another man. What do we say about that situation?
Okay,
So
I'll tell you what.
the other problem.
Yeah, we seem to be running out of time, and I'm going to give each of you 30 seconds, and that's all we have, to just sum up and say, what is the future in terms of, tackling this HIV case. Can I start with you, Prof. Salim?
The big challenge in HIV is how do we win the battle in preventing new HIV infections. This is not a time for complacency. This is not a time to say we've done enough. This is a time to continue our action. This is a time to continue scaling up treatment, and this is the time to put even more energy into preventing new HIV infections.
Mr. Yawa? Anele, 30 seconds. The future? What should be done as a matter of urgency? Okay, we seem to have lost that. It's on that note, folk, that we come to the end of our show then today. Please join us again next week, SABC News. A reminder to please share your views and comments via our Facebook page, SABC Health Talk, and follow us on Twitter at SABC Health Talk. Remember, you can watch the repeat of today's show at 2 p.m. and again Thursday morning at 5 a.m. I'm Dr. Salam Mutayu. Thank you so much for watching, and please do take care.
If we're talking health, then let's talk seriously. If we're talking health, then let's talk seriously. MedShield, embracing our members in good health since 1968. SMS MedShield to 33023 or talk to your broker to get your kind of care.